Good morning. Once again, welcome you for the fine morning for another edition of Online Anesthesia Postgraduate Teaching Program on Zoom platform, sponsored by Akrila and hosted by A1 Logics. Today we have three interesting topics. The first topic will be the OSCE-based conceptual learning of neuromuscular junction by Dr. Sarva Vinothini. That will be followed by cardiopulmonary bypass topic by the Dr. Sivaprasath sir. And we have a video session, interesting video session, that is the basics of echo evaluation by Kaushik Jothinath. He is none other than the author of the book Anaesthesia Review for DNP students. So this session will be coordinated by Dr. Gomadi Karmekam. I hand over the session to Dr. Gomadi Karmekam. Please introduce the speaker. Madam.
Good morning, everybody. The first session will be OSCE-based conceptual learning, neuromuscular junction by Dr. Sarva Vinothini. She is a consultant anesthesiologist at MIOT International Hospital. Welcome, Sarva. We can start the first session.
Is my screen visible, sir? Am I audible?
Yes, madam. Video and
audio clear, sir?
Clear.
Yeah. Good morning, everyone. Today's presentation is about an OSCE-based conceptual learning about neuromuscular junction. The DNB postgraduates have OSCEs in their practical examination. So when you're going to appear for OSCEs, you have a limited time. You have around 4 to 6 minutes to answer on OSCEs, and the questions will be very specific. So you need to have your concepts strong to answer those OSCEs and to gain those extra marks. And this will also aid in your conceptual learning. So today's discussion will be regarding neuromuscular junction. So instead of being a monotonous lecture, this is going to be in the form of a 20-20 match, like 20 questions. So the first question: draw a schematic representation of the motor end plate and label parts of relevance to anesthesia. What type of receptor is formed in the muscle, and what are the types of the receptor? Always remember 3 when you're going to speak about, when you're going to think or talk about neuromuscular junction, because it'll be easy for you to remember that way. So we are going to talk about a neuromuscular junction. You have to concentrate on 3 main regions: the presynaptic region, which consists of a motor neuron and its axon. The axon is bulbous at the terminal end, and it is filled with acetylcholine containing vesicles, which are more concentrated on the active zones that are ready for release. The presynaptic region also has a voltage gated calcium channel. And then we have a narrow synaptic cleft, followed by the postsynaptic region, wherein the muscle membrane is being transformed into numerous folds containing lots of acetylcholine receptors and acetylcholinesterase enzymes. In the electron microscopy also, we can see here that the presynaptic region has lots of acetylcholine containing vesicles, more concentrated on the active zones. And the postsynaptic region is flooded with the acetylcholinesterase enzyme and the acetylcholine receptors. And there is a narrow synaptic cleft in between. The acetylcholine receptors are of the NM type of the receptors, the nicotinic receptors, and the NM type of the receptor, muscle kind of a nicotinic receptor. And we are aware of the 2 kinds of the receptors. This receptor is a pentameric subunit, which has 5 units. It is arranged, it's stacked in a barrel shape. So both the isoforms have 2 alpha subunits where the acetylcholine comes and binds, and 1 beta and 1 delta subunit. The difference lies in this unit. The mature or the junctional form or the adult type has an epsilon unit, whereas the fetal type or the immature form or the extrajunctional form has a gamma subunit. But as we saw, we have to remember number 3. So there is a 3rd isoform that has now come up. It is called as a neuronal isoform, wherein all the 5 subunits are of the alpha 7 type. So this is called as a neuronal type or the alpha 7 isoform. So now we have 3 receptors: the adult or the epsilon type, and the fetal or the gamma type, and the alpha 7 type. Name 2 proteins that aid in the maturation of the neuromuscular junction. Mention the differences between various isoforms of the neuromuscular receptors. So the transformation of the neuromuscular junction occurs as follows. In the fetal stage, we can see that the whole length of the muscle is filled with the extrajunctional type of the receptor or the immature isoform of the receptor. The whole length of the muscle membrane is filled with this alpha 7 subunit or the gamma subunit. Once the neuron comes in contact with the muscle, slowly the transformation begins. All the receptors on the length of the muscle disappear and they get concentrated near the neuromuscular junction. Not only that, there is also transformation in the type of the receptor from the fetal isoform and the alpha 7 isoform into the epsilon isoform. So this occurs from the fetal period and lasts up to early neonatal period or early infancy period. So the things that help in the maturation of the receptor are two proteins that are secreted by the neuron itself, by the presynaptic neuron itself. It secretes two proteins. The name is agrin and neuroglin. So it helps in the concentration of the receptors near the neuromuscular junction, and it helps in the disappearance of the other kind of the receptors also. So in an adult form, we can see the entire neuromuscular junction being occupied by the mature kind of the receptor and total disappearance of the other kinds of the receptor throughout the length of the muscle. But what happens when there is states of functional or anatomical denervation, as in case of burns or as in case of any nerve palsies, what happens? Now this again gets transformed back into the fetal kind of the receptor. So this happens in the states of denervation. Again, there's proliferation of the extrajunctional receptors, and the type of the receptor also changes from the mature to the fetal form. So what if it changes? As we saw, this happens in the states of functional and surgical denervation. What happens because of that? Because the receptors are there in the whole length of the muscle, and these receptors are quite unstable when compared to the mature receptors. And they have a low conductance. They do not conduct very fast. They have a very low conductance. But the problem is they remain open for quite a long time. They remain open for around 2 to 10 times more when compared to a mature receptor. Because they are present in the whole length of the muscle and they remain open for a longer time, what happens? There is lots of potassium coming out when these receptors are being stimulated. So there's lots of potassium efflux and there's a risk of hyperkalemia when this happens. And these receptors are also very sensitive to scolin. Even 1/10 to 1/100th of the dose is enough to just depolarize these receptors. And the alpha 7 subtype is also resistant to the non-depolarizing muscle relaxant. So these are the issues. So when we have patients who have burns or who have states of functional surgical denervation, there is risk of hyperkalemia when we use scolin, and they are also resistant to the non-depolarizing muscle relaxants. What is MEPP with respect to neuromuscular junction, and what are the receptors that are activated to generate muscle potential? So this is the neuromuscular junction as we have already seen, and we can see here this is the acetylcholine receptor which is closed. We saw that it has got 5 subunits stacked in a barrel shape, and they just come together and close the receptor. So when even if it is bound by one molecule of acetylcholine, it still doesn't open. Both the alpha subunits has to be occupied, only then it will open. So suppose when there is a release of acetylcholine containing vesicle, and when 2 molecules of acetylcholine come and sit up on the receptor opens and allows sodium to come in and potassium to go out. So this causes a change in the membrane potential. But this change in the membrane potential is very, very minimal. When 1 quanta of acetylcholine is released, when 1 quanta or 1 vesicle contains around 5,000 molecules. So when 5,000 molecules of acetylcholine was released, it just changes the voltage to around 1 millivolt. So it produces a minimal change. So this is called as a miniature end plate potential. When compared to the end plate potential, you can see this is just 1 millivolt change. Hence it is the name. Hence it's called as a miniature end plate potential. And this is important to maintain the muscle tone. So this occurs spontaneously. So when we compare this with the action potential, so this is a miniature end plate potential where it is just 1 millivolt change. When this gets on to the end plate potential. So for the end plate potential to occur, numerous quanta has to be released. This voltage change is around 20 millivolts. And when this end plate potential is stronger enough to reach a threshold, then the action potential is triggered. So how does an action potential now occur? For an action potential to occur, the nerve has to be stimulated. So when and 3 main receptors come into play. One is the voltage sensitive calcium channel and the acetylcholine receptors, which are ligand gated. These 2 are sodium channels and this is a calcium channel. The difference between these 2 sodium channels are these are ligand gated. They respond to the molecule acetylcholine. So they open when acetylcholine comes in. But these are voltage-gated sodium channels, they respond to the change in the voltage of this membrane. So these three receptors, again number 3. So these three receptors have to come into action when you're going to talk about an action potential. So if the nerve is stimulated, when the nerve gets depolarized, the voltage-gated calcium channels also get stimulated, and they allow calcium to pass into the terminal bulbous area, which helps in the release of the acetylcholine containing vesicles. So now acetylcholine containing vesicles are released because acetylcholine comes and sits on this receptor. When both the alpha subunits are occupied, it opens this receptor and sodium comes in. So now when this potential is greater than the miniature end plate potential, because now lots of acetylcholine containing vesicles are released because of the calcium coming in and the vesicles being released. Now more than around 100 quanta are now released. So in that case, lots of receptors are depolarized, and now the potential that is generated is greater than the miniature end plate potential. Now this is called as the end plate potential. So when this end plate potential is stronger enough, it comes and depolarizes the surrounding muscle membrane also. So in that case, this voltage sensitive calcium channel also gets stimulated, and now this also allows sodium to come in. So in this way, the muscle action potential gets propagated and the muscle contraction occurs. So you have to remember these three receptors. So again, to recap, we saw the miniature end plate potential was because of the release of one quanta. Now, when the nerve gets stimulated, then we get the end plate potential. There around 100 quanta is being released, 100 quanta of acetylcholine is released. And this end plate potential is because of depolarization of the acetylcholine receptors. But this does not produce action potential. This has to cross the threshold, and that at that point, this will come and stimulate the voltage-gated sodium channels that are there in the perijunctional area. That will cause the action potential to propagate, and thus will stimulate the muscle contraction. What is margin of safety and what is its clinical significance? Each nerve impulse, when it comes, it releases at least 200 molecules of 200 quanta of acetylcholine, and each quanta containing at least 5,000 molecules. And this acetylcholine, number of acetylcholine receptors that are activated are also quite large, around 500,000. So if you see, it is half the number of receptors getting activated than the acetylcholine molecules that are released, because most of them are being degraded by the acetylcholinesterase enzyme before they come in contact with the receptor. And now the end plate potential is produced, and this end plate potential will trigger the voltage-gated sodium channel in the muscles, and that will again trigger the calcium channels in the T tubules and cause muscle contraction. The margin of safety here is the signal is being carried by more molecules of transmitter than that are needed, and they also evoke a response that is much, much larger than needed. In spite of this, only a small fraction is actually used up, and there's a lot that is kept up as reserve. So more than 75% of the receptors have to be blocked to produce a clinically significant neuromuscular blockade. Why is this important to us? Because more than 75% of the receptors have to be blocked for us to clinically see if there is any significant neuromuscular blockade. So there is residual neuromuscular blockade or the recuralization can very easily occur, and it can be very easily masked, and it can very easily be missed. So we need to be very vigilant. Identify this muscle relaxant and classify it. How is it metabolized? Name 2 more drugs metabolized in the same way and contraindication for this administration. This is succinylcholine. It is just 2 molecules of acetylcholine combined together. Succinylcholine chloride. It is an ultra short acting depolarizing muscle relaxant. It is metabolized by using pseudocholinesterase or butyrylcholinesterase enzyme. It is metabolized to succinic acid and choline. The other drugs that are metabolized in a similar way are mivacurium, procaine, chlorprocaine, and tetracaine. The 2 main contraindications for its use are malignant hyperthermia and hyperkalemia. The relative contraindications are any rise in the intragastric, intraocular, or intracranial pressure. How does succinylcholine produce fasciculation and later paralysis? Name another depolarizing muscle relaxant. Another depolarizing muscle relaxant is decamethonium. How does succinylcholine, being an agonist, produce paralysis? This is a very interesting concept. So I would ask for your attention here for a few more minutes. So to know about how succinylcholine produces depolarization but still causes paralysis, we need to know about 3 zones. Number 3 again. So we need to know about 3 main zones in the muscle. One is your junctional zone that is occupied by acetylcholinesterase receptors and the acetylcholinesterase enzyme. And the next is your rest of the muscle. But this intervening area is more important for us. This intervening area is called as the perijunctional zone. And in the perijunctional zone, we have this voltage sensitive calcium channels, which are more important for us to know how succinate colon produces depolarizing blockade. This voltage sensitive calcium channel are also there in 3 different states. One is the resting state, wherein the voltage gates are closed, and this is a time gate. This time gate is open. So this is the resting state of this channel. When nothing happens in the plasma membrane, the channel lies in this state. The voltage gates are closed and the time gates are open. So this does not allow the sodium to pass in. When a depolarizing current comes in, what happens is this voltage gate is stimulated and this voltage gate opens fast. At the same time, the time gate is also stimulated. So when the depolarizing current comes, the voltage gate opens very fast and it also stimulates the time gate to close. This closure occurs very slowly. So in the intervening time, the receptor is said to be in the activated state where it allows sodium to enter into the cell. After approximately 1 millisecond, irrespective of whatever happens here, irrespective of whether this is closed or not, the time gate comes and closes. At this point of time, even if this is open, the sodium cannot go in. So this is in the inactivated state. So these are the 3 states now: resting, activated, and the inactivated. This inactivated sodium channel again has to go back to the resting state. Again, the voltage gate has to close and this has to open for it to be ready to open again. If it is in this state, it cannot open again. This has to get back to the resting state, and only then it can be opened. So this has to go through this full cycle. From the resting state, it has to get back to the activated state once the depolarizing current comes in. So after the depolarizing current veers off in approximately 1 milliseconds, irrespective of whether the depolarizing current is present or veered, the time gate closes. And this has to get back to this resting state for it to be depolarized again. So this cycle has to happen between the 3 states. In which state are you people now? Activated, inactivated, or resting? So as we know, what happens during the normal depolarization. So we know that the acetylcholine receptors are occupied and the sodium comes in. So this membrane gets depolarized. At this point of time, the sodium channels, both are the sodium channels. So the sodium channels in the junctional zone and in the rest of the muscle, they still are in the resting state. So when this gets depolarized and when this end plate potential is bigger enough to depolarize this channel now, this sodium channel, which is in the resting state, now gets back to the activated state, and it allows the conductance of sodium inside. So this again transfers the potential again to the next bunch of the sodium channels, and they again get into the activated state, allowing sodium to come in. So in this way, the action potential gets propagated. So after this is activated, within 1 millisecond, irrespective of whatever is happening here, this gets back to the sodium channels get back to the inactivated state, and they cut off the sodium movement inside. But because this is being in a normal depolarization, because this is being acted upon by acetylcholine molecule, which also lasts less than 1 millisecond, because it is also fastly degraded by the acetylcholinesterase enzyme, this current also gets cut off, and this is also cut off. So when all this is cut off, the sodium channel now gets back to the resting state. So this is how a normal depolarization occurs. But what happens in case of persistent depolarization? Here, this colon also behaves like an acetylcholine molecule because it is an agonist. So it will also come and sit up on this receptor, and it will also cause depolarization. It will also cause an end plate potential to occur. So it will also cause the depolarization of this voltage gated sodium channels. So they also get activated, and it allows the current to pass in. And the further sodium channels also get activated. So this is how we see the contractions, or we see the fasciculations when scoline is first administered. So after being activated, we know that after about 1 milliseconds, they become inactivated and the sodium currents are cut off. So till now it is okay. So this is how the contraction occurs. But after this, what happens? Here comes the difference between scoline and acetylcholine. After this, what happens? If it's acetylcholine, it would have been degraded here by the acetylcholinesterase enzyme. But because this is not acetylcholine, this is scoline. Scoline, though it is an ultra short acting relaxant, the duration of action of scoline is much, much larger when compared to acetylcholine. So it persistently depolarizes this membrane. So because of this persistent depolarization, persistently it's sending up current here. So this channel cannot get back to the resting state at all. The further sodium channels can get back to the resting state because nothing happens here. But the sodium channel in this perijunctional zone, they are locked in the inactivated state. They cannot get back to the resting state. So what happens with colon is, you have three distinct zones. One is the junctional zone, where this colon keeps on depolarizing the acetylcholine receptors. And the next is your perijunctional zone, which is more important because the sodium channels here are frozen in the inactivated state. They cannot transfer the current that is happening here to the rest of the muscle. And we have the rest of the muscle which are in the resting state. So it is the perijunctional area, the voltage gated sodium channels in the perijunctional area, which mediate this colon mediated paralysis. So that is why colon, despite being a depolarizing muscle relaxant, despite being an agonist, it causes muscle relaxation. So because of its persistent depolarization, it does not allow the muscle to get back to repolarization. A 60 kg male with 60 years old with chronic liver disease has been posted for lap appendicectomy. He's been administered propofol, fentanyl, and 100 mg of scolan. Has been intubated. The procedure lasted for 1 hour. Spontaneous respiratory efforts were not observed even at the end of the procedure. The ABG and the BIS were normal. Similar history of delayed recovery has occurred in his brother during his surgery. What do you think is a probable cause, and how do you evaluate the cause? What will be your next line of management? So here, this patient has got chronic liver disease, and he also gives a history that his brother also had a delayed recovery. So we can think in terms of two things. We know that for this colon action to be terminated, it has to be metabolized by butyrylcholinesterase or pseudocholinesterase. This is present in the plasma. It is not present in the neuromuscular junction. It is present in the plasma. So butyrylcholinesterase deficiency can occur in various conditions and various medications also. In our case, in our patient, the patient had liver disease, which also causes butyrylcholinesterase deficiency, burns, pregnancy, hypothyroidism, and many other medications also cause butyrylcholinesterase deficiency. But even larger decreases in the butyrylcholinesterase activity will produce only a marginal increase in the duration of colon apnea. That is not really that very significant. So even if the butyrylcholinesterase activity is only 20% remaining, if around 70 to 80% of the activity is lost, only 20% remains, even then we can see the colon apnea only increases from 3 minutes to 9 minutes. So the most probable reason for our patient having apnea for more than an hour might be the presence of an atypical butyrylcholinesterase. How do we determine if the patient has atypical butyrylcholinesterase? In atypical butyrylcholinesterase, there is a mutation that is happening in the butyrylcholinesterase enzyme, and so it is not able to metabolize succinylcholine in the same way as it usually metabolizes. So this can be found out using Dubukine number. Dubukine is a local anesthetic which also inhibits plasma cholinesterase. So if the patient has a normal enzyme, his Dubukine number will be 80 and his response to scoring will also be normal. In case he has got an homozygous enzyme code for atypical butyrylcholinesterase, then the response to scoring will be prolonged by 4 to 8 hours. In case he's heterozygous, he'll be somewhere in between, lengthened around 50 to 100%. So might be our patient has homozygous coding for atypical butyrylcholinesterase. So this is a qualitative test. This does not determine the quantity of active butyrylcholinesterase. It only determines the quality of the butyrylcholinesterase. So what can we do now for this patient? We can determine the type of the cholinesterase and if possible the levels also. We have to just wait for the spontaneous recovery. We have to do neuromuscular monitoring and rule out phase 2 block that is occurring in the meantime. If it is urgent, we can try plasma exchange or plasma pheresis. The same patient. Now, the same patient, if he had been administered 200 mg colon, and if we don't get any history of any other history of any family member also having a prolonged colon apnea. Now, what do we think? Here, he had been administered a large dose of scolan. So we have to think in terms of phase 2 block. Phase 2 block occurs with prolonged infusion or repeated doses or large doses of scolan. Very rarely it can even occur in patients with atypical butyrylcholinesterase enzyme. What is phase 2 block? So we know that scolan acts as an agonist on the acetylcholine receptor, and it opens the sodium channel, and it causes and we saw how it causes the paralysis. What happens in phase 2 block is the receptors become desensitized. So even if the receptor is being the receptor is being sat upon by acetylcholine or scolan, the receptor doesn't respond at all. The receptor becomes desensitized. So what is the difference here? There is a desensitization of this acetylcholine receptor. So no depolarization occurs at all. Whereas in phase 1, we saw that depolarization occurs. What is the difference? Why should we know that? Because if the patient is in phase 2 block, if we are going to administer anticholinesterase enzyme, then that will aid in the resumption of the neuromuscular transmission. But if the patient is in phase 1 block and we administer the anticholinesterase enzymes like neostigmine, we will be aggravating the phase 1 block. So how can we judge if the patient is in phase 1 or phase 2 block? So for that, we have to do the neuromuscular monitoring only. So if we do the neuromuscular monitoring, we can see the phase 2 block resembles your non-depolarizing block. We have fade in response to train of 4 and tetanus, and we also have post-tetanic potentiation. This phase 2 block is mainly because of the receptor desensitization and also the action of scolin on the presynaptic acetylcholine receptors, which aid in the mobilization of the acetylcholine vesicles. What is the relevance of this picture to anesthesia? Who advocated its use? To which group does this drug belong to? What are the subgroups based on the chemical structure? So this here we can see that they have used D-tubercular, which is obtained from Chondrodendron tomentosum. It is an arrow poison that is used by South Americans. It was used as a muscle relaxant to kill animals, actually. Who advocated its use in anesthesia? Harold Griffith and Johnson in 1942 advocated its use in anesthesia. What is D-tubercular? It is a long-acting benzyl isoquinolinum type of non-depolarizing muscle relaxant. What are the types of non-depolarizing muscle relaxant? Again, number 3. So there are 3 types: aminosteroids and benzyl isoquinolinums, and off late we have fumarate diesters also. How do non-depolarizers act? Non-depolarizers are antagonists, so they does not allow any action on the acetylcholine receptor also. So they just sit and they do not allow the acetylcholine receptor to open. So this is the difference we see. So this is a normal acetylcholine receptor. Acetylcholine is an agonist. It sits, it opens the acetylcholine receptor for around 1 millisecond, and then it gets metabolized. Succinylcholine, as we saw, will be persistently depolarizing this, whereas a non-depolarizer will just lock it in the closed state. And how does the action wear off? So when the level of the non-depolarizing muscle relaxant decreases in the blood, the non-depolarizing muscle relaxant moves across the concentration gradient from the neuromuscular junction to the blood, and the action slowly wears off. This can also be hastened by the administration of acetylcholinesterases, which inhibit the anticholinesterases, which inhibit the acetylcholinesterase enzyme. Mention the relevant differences between cis-atracurium disylate and atracurium. What are the intubating doses of each, and what is Hoffman degradation? Atracurium is a mixture of 10 isomers, whereas cis-atracurium is a cis isomer, 1R cis isomer. It is 4 times more potent than atracurium. It has less histamine release. This is predominantly eliminated by Hoffman elimination of 77%. While atracurium predominantly undergoes elimination by ester hydrolysis, only less than 30% undergo Hoffman elimination. Less lodozin is produced, and the intubating dose of atracurium is 0.5 to 0.6 milligram per kg, whereas the intubating dose for cis-atracurium is 0.15 to 0.2 milligram per kg. Hoffman elimination reaction is a pH and temperature dependent reaction, wherein higher pH and higher temperature favor elimination. In Hoffman elimination, the quaternary ammonium group is converted to a tertiary ammonium group. How is vecuronium metabolized? What is the metabolites of vecuronium and its potency? What is the ED95 and advantages of rocuronium? Vecuronium is mainly metabolized by the liver, to a lesser extent by kidney. And of the 70% that is metabolized by the liver, 30 to 40% is excreted unchanged in bile. What happens in liver? It gets deacetylated to 3 metabolites: 3-hydroxy, 17-hydroxy, and 3,17-dihydroxy vecuronium. The 3-hydroxy metabolite has 80% of the neuromuscular blocking potency of vecuronium. Why is this important? Because when you are going to administer vecuronium for a prolonged time as infusion or in the ICUs for days together, then this metabolite will be the main reason for the prolonged neuromuscular blockade that is occurring. Rocuronium is largely excreted unchanged in bile. It is an intermediate acting non-depolarizer with the ED95 of 0.3 milligram per kg. When we increase, when we administer around 3 to 4 times the ED95 dose, we get an excellent intubating condition in 1 to 2 minutes. and the duration is around 20 to 35 minutes. But if we want an intubating condition similar to scolin, then we have to increase the dose further. So when we increase the dose further, we get an intubating condition similar to scolin, but the duration of action will be around 45 to 60 minutes now. The advantages are rocuronium is almost replaced scolin in rapid sequence intubation. Because it has no history, no risk of malignant hyperthermia, hyperkalemia, and no risk of phase 2 block, no rise in the closed cavity pressures also. And it is equally fast acting with higher doses, and it is reversible also. What is this reversal agent? What is its special feature with respect to its structure and pharmacokinetics? What is it specifically used to reverse, and what are the advantages? So this is Sugammadex, also called as ORG2659 law, and it is a synthetic gamma cyclodextrin. It is the first selective neuromuscular reversal agent, and it can reverse moderate to even deep neuromuscular blockage. So that is the main advantage. How does it do that? It does not have any chemical interaction at all. It is like it does not degrade rocuronium. It just traps rocuronium within its cavity. This trapping mainly occurs because of more of the physical interactions between the hydrophobic and hydrophilic interactions, the positive negative interaction. So no degradation occurs. The parent molecules just get trapped inside the hole of the Sugammadex molecule. It gets chelated. Whenever we see Sugammadex, I do remember this donut and vada. And this is how this chelation occurs. And the advantage of this is the reversal of rocuronium-induced neuromuscular blockade with Sugammadex is when you reverse it, it is almost equal to scolin. So it in fact faster than scolin. So even if you have profound neuromuscular blockade with rocuronium, when we administer 60 milligram per kg of Sugammadex, the reversal occurs in 1.5 months, even faster than that with scolin. So that is the main advantage of Sugammadex. So with Sugammadex, now rocuronium can even be used in rapid sequence intubation in patients who are suspected to have a difficult intubation. And Sugammadex doesn't have any muscarinic side effects as with anticholinesterase. So we need not co-administer it with any anticholinergics. So the risk of using atropine or glycopyrrolate can be totally averted when we use Sugammadex. Name any relaxant of the fumarate ester group, its advantages, and how they can be reversed. So there are two drugs, of which Gantacurum has already passed phase 3 trial and human trials. The CW002 is still under, still yet to be trialed in humans. So this Gantacurum is an ultra short-acting, non-depolarizing muscle relaxant of the chlorofumarate ester. This CW002 is a benzoquinolonium fumarate ester. The onset time is around 1.5 to 3 minutes. So very rapid acting, and the duration of action is also spontaneous recovery occurs within 15 minutes itself. With CW002, it said it's 25 minutes. And how does the spontaneous recovery occur? It occurs by two processes. One is the cysteine adduction, wherein the process is very fast, and the other one is pH sensitive hydrolysis. So it is very slow. So spontaneous recovery as such occurs very fast. So if you want to further increase the spontaneous recovery, then we can administer edrophonium or neostigmine or cysteine, which can aid in shortening this recovery time. So this seems to be a promising muscle relaxant in the future. What are the various methods employed in neuromuscular monitoring? Name few sites that are commonly employed for neuromuscular monitoring. Which muscle closely resembles the level of blockade at the larynx? The methods of neuromuscular monitoring can be qualitative or quantitative. Qualitative meaning it's subjective. So it's just like a clinical assessment of protruding the tongue, raising the head, tongue depressor test, all those things. Or we can use a nerve stimulator and visually see the response of train of 4, etc. Or it can be objective, which is reproducible and which is the preferred one. This objective types there's all kinds of myographies. One is your electromyography, wherein you record the compound muscle action potential. Kinemyography, wherein the movement of the muscle is recorded. Phonomyography, wherein the sound intensity is recorded. And the most commonly used is your acceleromyography, wherein the piezoelectric crystals are used and it measures the acceleration of the muscle, which generates some voltage in the crystal. And this reliably detects the TOF ratio. It can overestimate the TOF ratio, but what are the muscles that are commonly employed monitoring sites for neuromuscular blockade? One is your ulnar nerve, wherein you monitor the adductor pollicis for the adduction of thumb. Or we can use the facial nerve, we can stimulate the facial nerve, and we can monitor the orbicularis oculi. We can look for the closure of the eyelid. or we can monitor corrugator supercilii and look for the furrowing of the eyebrows, or the posterior tibial nerve can also be monitored. We can look for the flexion of the big toe. But we can see that the muscles are not uniformly sensitive. So not all muscles get blocked at the same time frame. So we can see here the diaphragm is the most resistant. So diaphragm is the last muscle to be paralyzed, and it's the first muscle to recover from the neuromuscular blockade. Next to diaphragm, you have the laryngeal erector muscles. So diaphragm is the last muscle to be paralyzed. Before that, you have the laryngeal erector muscle, and the muscle that closely resembles the laryngeal erector muscle is your corrugator supercilii muscle. So if you have to monitor the neuromuscular blockade for the to know at what time to intubate, then corrugator supercilii muscle closely resembles that of your laryngeal erector muscle. So that will be the ideal muscle to guide you for intubation. And we can see the pharyngeal muscles are the most sensitive and they are the least resistant. So this will be the first muscle to be blocked, but this is the last muscle to recover. The clinical significance of this is even when all this has recovered, even when the patient is able to hold his hand, the patient is able to generate hand grip, the pharyngeal muscle might still be blocked. This will lead to a pharyngeal incompetence and the microaspirations that are the major problems of your residual neuromuscular blockade in the postoperative period. How do you differentiate a depolarizing versus a non-depolarizing blockade using neuromuscular monitor? How do you assess the depth of the blockade when there's no response to TOF? What TOF ratio is considered safe or excludes residual neuromuscular blockade? So we can see the difference between depolarizing and non-depolarizing. In depolarizing, there is a uniform depression of the twitch. There is no variations. So all this show the same response. So with tetany, there is a uniform twitch suppression, teninophore uniform twitch suppression, double burst also. So everything is the same thing, and there is no post-tetanic potentiation also. But whereas with non-depolarizing, we can see there's a gradual decrease, this which is called as a fade. In TOF also, we can see the TOF rate, we will get a TOF ratio. Here the TOF ratio will be 1, irrespective of whether the twitch suppression is whether twitch suppression is 20%, 30%, or 40%, the TOF ratio will be 1 for depolarizing muscle relaxant. But here we can see the TOF ratio will be varying. TOF ratio is the ratio of the last fourth response to the first response. So we can see fade that is happening in response to tetany and TOF and non-depolarizing muscle relaxant. Double burst also shows fade, and there is a post-tetanic potentiation also is happening with non-depolarizing muscle relaxant. All these actions occur because of the action of the non-depolarizer on the presynaptic acetylcholine receptors. This presynaptic acetylcholine receptor helps in mobilization of the acetylcholine containing vesicles, and they aid in the release of the vesicles also. So this mobilization and release is being hampered, and that is why we have fade. And we also saw earlier that in a depolarizing blockade, when it gets on to the phase 2 blockade, it starts mimicking like the non-depolarizing blockade. So that is also not to be forgotten. So if how are the levels that happen with a neuromuscular blockade using a non-depolarizing muscle relaxant? So we have, once we have administered the non-depolarizing muscle relaxant, we can see there is a twitch suppression, and eventually when the block is very intense, we can't elicit any TOF count at all. So when we can't elicit any TOF count at all, we have to look for post-tetanic count or post-tetanic potentiation, post-tetanic count. So we can see if the post-tetanic count is also 0, then the block is said to be intense. So when slowly the neuromuscular blockade wears off, we can see the post-tetanic count to resume. At this point, there is no TOF ratio happening, but we can see some post-tetanic responses. So at this stage, the patient is said to be in deep block. So when we can't elicit any TOF count at all, we have to look for post-tetanic counts. So once the blockade reduces, once the blockade slowly wears off to 90% or so, we can see the TOF response coming up. So when we get one response, around 90% of neuromuscular blockade is present. When we get 2, around 80%. When we get 3, around 70%, 75%. So only after seeing all the 4 responses to TOF, only then we can think of administering anticholinesterase. So even with the 4 responses there, still around 75% of neuromuscular blockade can be there at the level of the muscle. Remember what we saw in the margin of safety. So around 75% of the receptors have to be blocked to know any clinically significant neuromuscular blockade. So even with the TOF, even when we see 4 response, that doesn't guarantee full recovery. So even at this point of time, 75% of the receptors can still be blocked. So we have to get a TOF ratio of at least 0.9, more than 0.9. for us to exclude any clinically significant residual neuromuscular blockade. It should be more than 0.9 when we are recording with mechanomyography or electromyography, and it should be more than 1 when we use acceleromyography. So we can see here only when it's more than 0.9, we have good pharyngeal tone. Before that, whatever clinical things we do, whether the patient is able to generate good vital capacity, able to cough, able to protrude his tongue, able to generate more negative inspiratory force, 5 seconds sustained head lift, all this can occur, but still there might be a pharyngeal incompetence which might lead to aspiration or which might lead to falling back of your tongue and collapse of your pharyngeal muscles and eventual hypoventilation. So to exclude any clinically significant neuromuscular blockade, the top ratio has to be 0.9 when recorded with MMG or AMG, and it has to be 1 when recorded with acceleromyography. What is the basic pathology in myasthenia gravis? What are the medications they are on? What are the diagnostic tests? Few significant anesthetic considerations. Myasthenia gravis, it is an autoimmune disease wherein antibodies are against the alpha subunit of the nicotinic NM receptors. So the antibodies are against the alpha subunit. In some patients, even against muscle-specific kinase has been detected. These patients are mainly on anticholinesterase therapy. That is the mainstay of their therapy. They will also be on steroids and other immunomodulators, but main thing of our concern is your anticholinesterase therapy, usually pyridostigmine. And the test that is commonly employed to detect is the edrophonium test or tensileon test. After administration of this, we can see an increase in their muscle power. What are the concerns that we have? So here we can see in patients with myasthenia gravis, the junctional folds totally disappear. There are no folds and crisps at all. And the number of receptors also is totally disappeared. And we can see the end plate potential in a patient with myasthenia gravis is just above the miniature end plate potential in normal patients. So that is all that is all the muscle power they have. So the problems that we have is they are more prone for aspiration because of bulbar muscle weakness. And we have to evaluate the pulmonary function test also because they are, because they have intercostal muscle weakness also. And they also have, in some cases, they also have abdominal muscle weakness also, and they'll not be able to generate good cough. So we have to, these two are our major considerations, and we have to evaluate all these things using pulmonary function test preoperatively also. And they can at any point of time go in for a myasthenic or a cholinergic crisis. And regarding the drug usage, if you are going to use colon or mivacurium, we have to use a larger dose and we have to expect a prolonged action in them because these patients are already on this anticholinesterase therapies and all. And they very rarely require muscle relaxants actually. If at all they require it to be only for a tracheal intubation, but most of the time the whole procedures can be done even without the usage of muscle relaxant. So if at all you're going to use any non-depolarizing muscle relaxant, you definitely have to use a neuromuscular monitor. The response is totally unpredictable, and hence you have to start using it in incremental doses, 10% and see the response and then only give. If you have Sugammadex, it will be beneficial. A 5-year-old child is scheduled for tonsillectomy. He has underwent inhalation induction with halothane, and he was intubated using Scolan with difficulty because of mesospasm. This is the ETCO2. What is the diagnosis and what are the features and management? So it is a 5-year-old child who has been induced with the inhalation agent, and he was intubated with Scolan, and there has been a mesospasm. And here in ETCO2, we see an exponential rise in the ETCO2. In just 4 breaths, we can see the ETCO2 has jumped from 40 to more than 60. So we have to think in terms of malignant hypothermia. During a normal depolarization, the action potential passes through the T tubules and it stimulates the calcium channels here and it releases calcium. So during a normal action potential, it traverses through the T tubule. It stimulates this dihydropyridine gated ryanodine receptor. This is the ryanodine receptor. This is the sacroplasmic reticulum. So when the depolarization occurs, this dihydropyridine receptor is activated. So when this activated, it opens the gate for this ryanodine receptor and calcium jumps out. So this helps in the actin-myosin interaction and muscle contraction ensures. So immediately after the depolarizing current veers off, this gate closes, and once the contraction is over, this calcium is released from this muscle, and the calcium is again pumped back using ATP into the sarcoplasmic reticulum. So this is an ATP-dependent process, not just the contraction, even the relaxation of a muscle is an ATP-dependent process. What happens in malignant hypothermia? It is a pharmacogenetic disorder. There is an abnormality in chromosome 19 that codes for the ryanodine receptor. What happens here is this ryanodine receptor does not close at all. when does these things occur? Because they are always normal. When they get exposed to some triggering agents like your inhalation agents and scopolamine, it is at that time that this receptor behaves like this. And till now, why it happens so is not found out. This happens only when they are getting exposed to some triggering agents like volatile agents, malignant hyperthermia. Very rarely some extreme heat or vigorous exercises can trigger. What happens is ryanodine receptor is persistently open. It does not close at all. And so there is large and continuous efflux of calcium. Calcium is actually very, very lethal when it is in a higher concentration intracellularly. That is why calcium is kept inside the sarcoplasmic reticulum. So when this calcium, when there is large amounts of calcium inside the cell, our body tries to push it in. That is why nature has given this calcium dependent ATPase pump to keep the levels of calcium at control. So when there is enormous amounts of calcium, this ATPase pump keeps on tries to keep on sending the calcium inside, but because this channel is still open, the balance is not achieved at all. So this gets exhausted and all the ATPs gets used up. And because there's large amounts of calcium, the muscle also keeps on contracting. This is also an ATP consuming process. So with all this process, there's lots of ATP getting consumed and lots of oxygen used up, lots of carbon dioxide, heat and lactate produced. So those trigger all these things. And because at some point of time when the ATP levels become critically normal, the integrity of the muscle membrane is lost and it leads on to rhabdomyolysis. So the main symptoms of malignant hyperthermia are because of the markedly increased metabolism, the increased sympathetic activity, and the muscle damage because of the rhabdomyolysis. Because of markedly increased metabolism, we have increased CO2 production, increased oxygen consumption, acidosis, etc. And because of muscle damage, we have this muscle spasm, rigidity, hyperkalemia, myoglobinuria, myoglobinemia, and definitely fever because of their increased metabolism and rigidity. So how do you treat? You have to stop some hot dude, better give ice fluids fast as the mnemonic that is used. You have to stop all the triggering agents, start hyperventilating with 100% oxygen, give dantrolene 2.5 mg per kg, bicarbonate 1 to 2 milliequivalents per kg, glucose and insulin to push the potassium inside, and cool IV fluids, iced lavage of the stomach, and cooling blankets, external cooling. Then we have to do fluid output monitoring, also administer furosemide for forced alkaline diuresis also. What is the pH of dantrolene? What solution is used to reconstitute it? How many vials of dantrolene are needed to address the malignant hyperthermia crisis? What are the new formulations of dantrolene and its advantages? Dantrolene is packaged with sodium hydroxide and with a pH of 9.5. Sodium hydroxide is used, and this high pH is mainly to aid dissolution of the dantrolene. And we have around 3 grams of mannitol in each thing, which converts the hypotonic solution to isotonic solution. And this is reconstituted using sterile water and not using saline. Pre-warm sterile water is better. That will aid dissolution of dantrolene. So mixing up of dantrolene itself is a tedious process, and we need at least 36 vials of dantrolene to address in malignant hyperthermia crisis. So to obviate all these things, a new formulation of dantrolene was now discovered. It's Rhinodex. It is being formulated. So this to administer this, we need just 5 ml of the diluent volume, and this gets reconstituted very fast. In less than 1 minute, we'll be able to reconstitute this, and the mannitol content is also very less, but this is equally costly. Identify this. When is it used? What are the drugs or agents preferred when anesthetizing such patients? This is also called as vapor clean. It is an activated charcoal filter. This is mainly used when we suspect a patient, when we take patients who are malignant hyperthermia suspects, or when we are already in a malignant hyperthermia crisis. The advantage is when you just fit this into the mission, and if you flush the mission for 90 seconds, your mission is ready to be used for the patient. Wherein if this is not there, you need at least 120 minutes, anywhere between 160 to 120 minutes to flush the mission, depending upon the type of the mission. So with this, that mission can be used again in 90 seconds itself. So what are the triggers for malignant hyperthermia? Are scopolamine and all inhalation agents except nitrous oxide. The safe agents are all IV anesthetic agents, all other muscle relaxants except scopolamine, opioids, local anesthetics. This is the last question now. We have the 50-year female who's COVID positive, who had a CT scoring of 20 by 25. It is day 5 for her in ICU and day 3 of mechanical ventilation. Today, they have stopped the propofol infusion, and this device was inserted to give her sedation. Half an hour later, the nurses note a huge rise in the EtCO2, temperature, and heart rate. What are your differential diagnoses, and what do you think will be the likely cause? So what are the things that will come up to your mind? Now they've changed they've added something on now, and the sedation has been stopped, and now we see a rise in EtCO2, temperature, and heart rate. So what could be there? It could be an insufficient sedation, it could be an aggravated sepsis, hypoventilation, or any ventilator malfunction, any undiagnosed pheochromocytoma or thyroid storm, any intracranial hemorrhage also. But we should also think of malignant hypothermia because the thing that they have inserted, the device that they inserted is called as Anaconda. It is an anesthesia conservation device which encompasses vaporizer, the circle system, tactile filter, and HME. This anesthesia conservation device, for this, the inhalation agent is actually administered via syringe, and you have an evaporation rod inbuilt in that, which vaporizes this. And these vapors are actually trapped by this activated carbon field. So when the patient expires, this anesthetic molecules trapped in that, and carbon dioxide is let out. When the patient again takes in the breath, the anesthetic agent is again transferred to those molecules to the patient. So this is used mainly to conserve the anesthetic agent, and this was devised to provide sedation in the ICUs. So when we have started using inhalation agent to provide sedation in ICUs, we have to also know that malignant hypothermia can also occur in ICUs. So this is the end of the lecture. I hope with this only we started. We started with the first question was to draw a schematic diagram of the neuromuscular junction. So I hope after this lecture you all will be now able to understand this better. So just to recap, once the action potential comes in, the calcium channels are activated, calcium enters, it causes exocytosis, and acetylcholine is released. When this acetylcholine, two molecules of acetylcholine sit on the acetylcholine receptor, sodium, the channel opens and sodium comes in and potassium comes out. When with one molecule, nothing happens. This acetylcholine is rapidly degraded by the acetylcholinesterase enzyme. When this when the potential that generates, the end plate potential, when the end plate potential is strong enough, it then gets transferred to the surrounding voltage gated sodium channels, and we know about this voltage gated sodium channel also. It has got two gates, the voltage gate and the time gate that we saw the three states that they are in. So once these are activated, the action potential just propagates, and when this action potential propagates, it also depolarizes the T tubules. When the T tubules are depolarized, it opens up the dihydropyridine gated ryanodine receptor. So this receptor now sends out calcium, and it helps in the muscle contraction. So thank you for listening.
Thank you, madam. You have given so much of information in a short time. Over to Gomadi, madam.
Thank you so much, Dr. Sarva Vinothini. I think you have completed the entire spectrum of the physiology of neuromuscular junction. You've covered muscle relaxants, reversal agents, and monitoring, and the pathophysiology diseases associated with neuromuscular junction. We can take the questions in the chat box since we are running short of time. May we go on to the next session? Dr. Sivaprasath, Asst.Professor, Institute of Anesthesiology, Madurai Medical College. His topic will be cardiopulmonary bypass, DHCA, and off-pump management. Over to you, Shiva sir.
Yes, ma'am. Thank you, ma'am. Good morning, everybody. Is my screen visible and audio clear? I think there are some issues in my audio. I'll make it as clear as possible. Welcome to the lecture series of online anesthesia and this month's cardiac anesthesia program. Today's topic is procedural management of cardiopulmonary bypass. So I already know that many PGs here would not have been able to witness a cardiac theater because they don't have one in the premises. So I'll keep my presentation very simple, try to address you with some pictures and videos. So going into the presentation, the first few slides I'll talk about introduction. There are three types of cardiac surgeries. The first type is the closed heart procedure where you don't open any cardiac chamber. The examples are CABG, pericardectomy, closed mitral commissurotomy, and PDA and PDA ligation or vascular diversions. Surgeries which need opening of a heart chamber are like septal defects, ASD, VSD closure, we have to open the chamber, or a valve repair or replacement, you have to open the chamber and do. So this is another type of surgeries. The recent developments are minimally invasive cardiac procedures where you will have to open the procedure. It could be either open or close, but thoracotomy becomes very optional. So here we have minimally invasive coronary bypass surgery and cardiac valve repair also. So these are the three types of surgeries. But for all these surgeries, you need a bypass pump. So what are the functions of bypass? There are four functions. The first is diversion of blood from heart to provide a bloodless surgical field. And the second one is providing systemic oxygenation and carbon dioxide removal. The third is pumping blood in the aorta for systemic perfusion. The fourth is protecting the organs with help of systemic cooling and then rewarming the patient when the bypass is terminated. So with these four functions, you can use the cardiopulmonary bypass in four types of cardiac surgeries. That is, when you want a bloodless field as an ASD or VSD or valve repair, or you might use the CPB just for a circulatory support when there is a hemodynamic disturbance, as in a case of CABG or a vascular surgery. And sometimes only for oxygenation CPB may be used. That may be in cases of a ECMO, or sometimes even for an organ protection as in hypothermia. Suppose a patient has had a cardiac arrest, you want to induce hypothermia, you can use a CPB. So these are the four uses of cardiopulmonary bypass. So today we are going to learn how to conduct a CPB in the pre-bypass period, in the intra-bypass period, and how to wean from a bypass. We'll also additionally see what is a deep hypothermic circulatory arrest and how to do a off-pump coronary bypass. And if time permits, I'll also tell about some additional features of unconventional bypass. So this is the basic bypass circuit components. We have a venous cannula, we have a reservoir, we have a roller pump, oxygenator, a heat exchanger, a filter, and an aortic cannula. These 6 or 7 are the basic components. In a few minutes, we'll just see what are the salient features of this. The venous cannula is a half-inch. If you look at the bypass proceeding, you will see a lot of cannulae that are like jammed wires, like how we see a computer console behind a lot of wires. You won't understand what it is. Similar way, a new person entering into a cardiac will get confused. So the biggest tube which is there is the half-inch tube. That is the venous cannula. So that tube is adequate to conduct 5 liters per minute from the patient into the venous reservoir. So, and if you fix that tube into a roller pump, it can deliver 40 ml for 1 ton of the roller pump. See, roller pump, 1 foot will be placed into the and occlusion head will be there. But once it turns, it will deliver 40 ml into the patient. So the venous reservoir is a huge tub. It's a 3 to 5 liter sump. The main function is it buffers the inflow and outflow. See, from the patient, you're drawing in blood, and through the roller pump, you're giving it to the patient through the aortic cannula. Sometimes what will happen is the inflow might not occur properly. So at that time, you might not be able to deliver a aortic flow. At that time, this reservoir will help in buffering that. It also helps to remove the air bubbles that can enter the CPB from the venous lines, and it acts as a port for drug administration. The pumps, there are 2 types. One is the roller pump and the centrifugal pump. The important difference is that the roller pump is an occlusive one. It uses occlusion head and it presses on the tube to push the blood into the circulation. Whereas a centrifugal pump uses the energy that is derived from a revolving cone. A rotating cone imparts centrifugal energy and it pushes it a bit. The main difference is there might be RBC and a platelet damage when you use a roller pump, but centrifugal pump, it is not there. In roller pump, there's always a risk of air embolism, whereas in a centrifugal pump, if an air enters into the pump will stop. So the air embolism risk is not there. But the main advantage of roller pump is that it can be either used to suck the blood or push the blood. Whereas in case of centrifugal pump, only pushing the blood is possible. Sucking, as you say, sucking the blood from a cardiotomy or the bleeding places, that suction is not possible. Only pushing the blood into the heart is possible. Coming to oxygenators, in my day, when I was doing a postgraduate, we were using bubble oxygenators, where from this venous reservoir, the blood will flow into a tub, and from the base of the tub, there will be oxygen bubbles coming in. That will give oxygen as well as remove carbon dioxide, but it has high risk of air embolism. So now we have stopped using it, and we are using membrane oxygenators where blood moves in one direction, oxygen moves in the opposite direction. In this interface, there is silicon sheet, and the oxygen diffuses into the blood. So there is no risk of air embolism in a membrane oxygenator, but it still can occur, but the chance is very less. Coming to the arterial cannula, it's the smallest, not the smallest, the middle smallest tube, which is 3 by 8 of inch, and one rotation can deliver 25 ml. The smallest tube is all the suction and the cardiopulmonary delivery lines, just quarter-inch size. That is the smallest tube we can see on that field. So now you can see that the whole pump is a continuous one, and there is a lot of air into it. Before starting the pump, you should do something called priming the pump. So what is priming? All the circuit tubing and the venous reservoir is filled with fluid, whatever it may be, blood or crystalloid, so that it will maintain continuity at the onset of bypass. When you draw in blood and start pushing in, the air should not go in. So first the prime solution will go in. That is the function of a prime. The prime volume is 20 to 25 ml per kg, and 200 ml to 300 ml is kept in the reservoir, and 800 ml is in the tubings, that is the venous and the aortic cannulae. How to prepare a prime? So I have shown the very commonest way of preparing a prime solution, which you can answer in your exams. For this, you will have to add a balanced solution like ringer lactate 800 ml, add a buffering soda bicarb 100 ml, mannitol to produce antioxidant effect, that you have to add 100 ml, and dexamethasone for the anti-inflammatory effect, and heparin for anticoagulation. All these together, they will mix in a solution and fill the all the cannulae and the venous reservoir. So I am showing a small video here. See, you can see the ringer lactate is there. All the contents are added to it, and they are pushing the prime solution into the all the cannulae. So what happens if you give such 20 to 25 ml of crystalloid clear fluid into the patient? What happens is it will hemodilute. So once this prime is given, pushed into the patient on the initiation of bypass, the patient will become severely anemic. The hematocrit will fall down, and because of this, there will be reduction in oxygen delivery, and there will be severe vasodilatation, which will lead to hypotension, and all the drug concentration. You might have induced the patient, and you're starting the pump. So all your muscle relaxant, your opioids, your anesthetic depth will go down. So these are the 4 problems with hemodilution. So is hemodilution only a problem? No. After hemodilution, and when you start the pump, you will have to cool the patient. Once hypothermia sets in, it will increase the viscosity of blood, and the microcirculation will slow down. But this hemodilution will offset the effects of increased viscosity, and it will improve the microcirculation. So there are advantages of prime solution also. So what this anemia, how much is acceptable? Hematocrit of 24 is acceptable. Is there a method to detect how much of anemia is going to occur in a patient even before he is instituted bypass? Yes, there is a method. So let's look at an example. See, we have a 70 kg male here who is going to undergo a mitral valve replacement. Now I have put him into the theater, and I'm going to use a prime solution on him. So after giving the prime, the resultant hematocrit will be his pre-op red cell volume divided by the total blood volume plus the prime volume. So let us see how to calculate this. So you all know how to calculate total blood volume. His weight is 70 kg, and because he's an adult male, he has 75 ml per kg of blood volume, which when we multiply, we get 5250 ml. That is his total blood volume in the body. So his prime volume, I already told you, 20 ml per kg should be used. So for 70 kg patient, you will need 1400 ml of prime. How to calculate the pre-op red cell volume? It can be obtained by multiplying this blood volume into his hematocrit. How is this hematocrit obtained? That is got by obtaining the first ABG. Once you shift the patient into the theater and do a ABG, you will get the lowest value. You can see that the hematocrit is 39. So you multiply from this 5250 into 0.39, you will get 2050 ml. So that is his total volume of his RBCs. That is called the pre-op red cell volume. That is going to get diluted in a larger volume. That is his total blood volume plus his prime volume. So the resultant hematocrit is 2050 ml in 5250 plus 1400 ml. That will compute to 0.33%. So what has happened? You have taken this 1400 ml, added into the patient. The hematocrit, which was 39, has become 0.33. You have to calculate for every patient and tell the perfusionist whether you will have to add some packed cell into the pump or not before starting the bypass. So that will decide whether you need a transfusion prior. So let us briefly see the extracorporeal circulation. See here, this is the heart, this is the cave end, the vena cava and the right atrium. The cannula is inserted into it. Blood drains from here by gravity into the venous reservoir. Remember, we don't suck the blood from the venous side. It is always by gravity, it drains into the venous reservoir. From here, it goes into the pump where mechanical energy is added into it and it is pushed into the oxygenator and heat exchanger. From here, blood is returned back into the systemic circulation through the aortic line. This is the basic overview of how the blood flows from the patient to the patient back after getting oxygenated. Additionally, you can see that there are vents and suction. We can suck blood from the field and from the chambers of the heart. See, when the surgery is proceeding, slowly blood will start getting accumulated in the left ventricle. That is not good. So you will have to vent the heart, remove the air and blood which is getting accumulated. There is also suction. And the other thing is the roller here, which is going to deliver your cardioplegia. So from the oxygenated blood, cardioplegia solution is prepared and is injected into the aortic root. So that also needs a roller pump. So these are the basic circuit diagram of the cardiopulmonary bypass. We will see a video of how we start a surgery. So after giving pre-medication, we shift the patient into the OT and fix ECG, complete ECG leads on him. Then with local anesthesia, we put an arterial line. So whenever we have a sick patient, we might also need to put a CVP or a PA catheter with local anesthesia before inducing anesthesia. But whoever it is, we start putting arterial line under local anesthesia. And now see, you have got a good trace there. We are inducing the patient at the same time. The perfusionist is also getting ready with the pump. So after induction, intubation, we put a central venous catheter and fix it. We all have general thing is that the distal end of the CVP should always be connected to the transducer. And we use the blue line without a three-way connector for NTG infusions and the yellow one for inotropic support. The next one is the TE insertion. And then we look at the proper TE image to tell the surgeon, see this is the MVR. So we have focused on the mitral valve annulus and I'm showing how much of regurgitation jet is there to aid in the valve replacement. Next is the temperature probe. So to complete it, see this monitor has all the recordings, ECG, an arterial trace, a CVP trace, a ETCO2, and the temperature. Everything should be ready before starting the surgery. So pre-bypass preparation, I have induced the patient. Now the patient is ready to the surgeon. The surgeon starts the surgery with an incision sternotomy. We'll briefly look into what all should be done during incision sternotomy. And after sternotomy, the heart is exposed by pericardectomy and the surgeon identifies the great vessels and does a pursing suture on the aorta and the vena cava. And once this is done, the main important step here is the anticoagulation. You have to give heparin to this patient because the whole extracorporeal circuit through which you are going to run the blood is a foreign body. So it will strongly activate the intrinsic coagulation system and the surgery itself will activate the extrinsic coagulation system. So to tackle the activation of intrinsic coagulation system, you have to give heparin and only after full anticoagulation, you have to allow the aortic cannulation to proceed. So the next step is aortic cannulation. Then the surgeon does a venous cannulation and after that, a partial bypass is started. And by carefully draining all the blood away from the patient, you will go into a full bypass and now you have an empty beating heart. And after that, you have to deliver cardioplegia and arrest the heart to get an immobile heart. In brief, this is the whole outline of what is to be done in a cardiopulmonary bypass. During incision sternotomy, you will have to additionally give good anesthetic depth and analgesia because it's a very stressful period. So the patient may land up in hypertension, tachycardia, and tachyarrhythmias. So ensure that he has adequate anesthetic depth and analgesia. And remember, you will always have to have heparin standby, especially when you do a redo. There were many instances when the patient has had a catastrophe when the sternotomy was done by injuring a great vessel, and we had to go to emergency bypass. So have heparin standby always near you when you start the sternotomy. And positive pressure ventilation should always be stopped and lung deflated to avoid parenchymal injury. During this time, the blood pressure should be 100 millimeters of mercury or less, because if you do so, the chance of injuring heart and great vessels is greatly reduced, and the sternal bleeding, that is a marrow bleeding, so that will also be less when you keep the BP under your control. So I have already told you, for a pre-bypass period, you have to give full anticoagulation. For that, you have to give heparin sulfate in a dose of 300 units per kg. After 3 minutes, you have to do a activated coagulation time. See, heparin will deal with the intrinsic system. For intrinsic system, the test is APTT. But if you do an APTT, what will happen is it will become, at this high supranormal doses of heparin, it will become indeterminate. So to have a point of care testing, we are having ACT, where the kaolin or salate is added into test tube and it is tested. This kaolin and salate, what it will do is it will do a thrombin activation and will reduce the time. So normal ACT value is 80 to 120 seconds. So if the ACT becomes prolonged to 480, it is said that anticoagulation is complete. The field bleeding can be sucked. So whatever bleeds after this ACT becomes 480, you can be sucked into the CPB itself, and the blood wastage is not there at all. So the blood salvage can be started as soon as the anticoagulation starts. So you have to check the ABG, baseline temperature, and give adequate anesthetic drugs, check your monitor, especially the invasive BP and CVP line. You have to check them, level them, and see whether the waveform is perfect. Because once you go into bypass, all these waveforms will go. And once you return, if there is some problem in the preoperative pre-bypass period, you might not know what has happened. And if you have given a pulmonary catheter, make sure you withdraw the catheter 3 to 5 centimeters, because on once the blood is completely drained from the pulmonary circulation, this pulmonary catheter can damage the pulmonary capillary, and post bypass you will have pulmonary hemorrhage. So withdraw the pulmonary catheter. And now you are checking the ACT that is greater than 480 seconds. Maintain a systolic BP at 100. And if you are using nitrous oxide as a part, cut it off at this point before aortic cannulation. So at the time before cannulation, you have to apply carotid pressure so that any calcium or embolus in the aorta does not go into the carotid artery. Once it is inserted, the cannula is meticulously de-aired. So this is the last part of circulation, but that is inserted into the aorta first. So it might carry bubbles into the circulation. So meticulously de-air and connect it to the arterial end. And then you have to measure the line pressure. Line pressure means the aortic pressure through the aortic cannula is measured by the perfusionist. It should be equal to radial aortic pressure. If it is not equal, it means the cannula is not in position, or it might have dissected the aorta. So these 4 or 5 steps you have to routinely follow: anticoagulation, maintaining a BP of 100, meticulously de-airing, and checking the line pressure. You have to follow with every aortic cannulation. Remember, it is a very crucial step. Any problem in this might totally damage the patient. Once an aortic cannula is secure into the patient, the prime solution, which is in the CPB, is available for direct transfusion into the patient. In case there is any crash, you can directly give it and the patient can be resuscitated with help of a aortic cannula. So let us see a video of how we do an aortic cannulation. Now my ACT is 750. The BP I've kept it at 8750. Good for cannulation. The surgeon is opening up the aorta and he's going to push the cannula inside. So aortic cannula, after a full anticoagulation, is pushed inside, and blood is gushing out through the cannula. See, he is de-airing the aortic cannula And next heel, the one in the clamp is the aortic end. He's dehydrating it completely and connecting it to the aortic cannula. So the arterial end of CPB is now connected to the aortic cannula, and whatever bleeding was there can be sucked into the CPB line itself. The second step is the venous cannulation and starting the bypass. The surgeon decides to either cannulate the right atrium or the vena cava. If there is no need to open the right atrium, just a right atrial cannula or a single stage cannula can be placed. But like in a repair of ASD, you need to have an empty right atrium. At that time, SVC and IVC should be separately cannulated and blood should be drained off from the right atrium. To once the cannula are in, to facilitate venous return to go into the venous cannula and reach the reservoir, you will have to increase the operating table size height from above the venous reservoir so that blood flows with the help of gravity, and sometimes put in a Trendelenburg position. So only when you do this, because I already told you, the venous return is not taken by suction, it drains by gravity. To aid in gravity, you raise the height and put in a Trendelenburg position, and surgeon would have already placed a clamp in the venous line. You will unclamp it, the blood will gush into the venous reservoir, and the perfusionist draws this blood, he oxygenates it and return it to the patient through the aortic cannula. So this is how the CPB works. And at this time, I already told you, prime solution will start moving into the patient and it will produce hemodilution and hypotension. You will have to manage that. So at this time, this is only a partial bypass. Remember, the blood is draining out through the cannulae, going to the CPB and coming back through the arterial end. But at the same time, the heart is also, right ventricle is also ejecting to the pulmonary circulation. So you have to ventilate the lungs at this phase. This is called the partial bypass, when heart is ejecting into the lungs also. So, but if you observe in the ETC, what will happen is, because the lung perfusion to the lung is decreasing, the ETC gradually falls down. So as you remove more and more blood from the right ventricle, right atrium, and push it into the bypass, the ETC will start falling down. But if your purpose of CPB is only for a partial support and oxygenation, the surgery can be, suppose it's a pericardectomy or CABG, the surgeon can start at this point itself. Surgeon need not wait till the heart is fully deflated. From this itself, he can start. But if the purpose of CPB is full circulatory support, you need to initiate a full bypass. That is, the venous drainage is slowly increased, so until the time when all blood in the IVs and SVC is drained away from the heart. And at this point, there is no pulmonary circulation, and ETC literally becomes 0 or 0 to 7. Now you need not ventilate the lung at all. The full ventilation part is taken by the CPB. The ventilation can be stopped. Now here we have empty beating heart. So the heart will still be beating. You can't open the chamber and do the surgery. If you want an immobile heart, you will have to arrest it. So to arrest it, what we do is, we'll just see a small video. See here, these two are the venous cannulae, taking out blood and pushing it through, after oxygenation, pushing it to the patient through the aortic line. It's an empty beating heart. So how to prepare a cardioplegia? The initial volume which we use is, I'm talking about the crystalline cardioplegia. We use 15 ml per kg as the initial dose. 1/3 of the dose, we choose a potassium-rich solution like isolate M or a ringer lactate. 2/3 of the volume is by oxygenated blood. So only after the pump starts and the perfusion starts oxygenating, he draws in the blood that is from the pump, and he adds it into the, this is the cardioplegia flask. He adds it into that, and he adds another special solution called bioplegia. This solution is rich in magnesium, potassium, and procaine, and this flask will cool the cardioplegia to 15 to 12 degrees centigrade. We cool the patient from 37 to 32 degrees, but heart is cooled much more less. That is, it's at 15 degrees to enable good protection during periods of no blood flow at all. So this is how we arrest the heart. See, this is the cross clamp which you have to apply to isolate the systemic circulation and the coronary circulation. See here, you have the systemic circulation going on into the patient from the aortic cannula. And because of applying the cross clamp, the coronary circulation gets isolated. Now we will have to insert a cannula called a cardioplegia cannula, and through this you have to deliver the cardioplegia into the aortic root. that will go into the aortic root, and with the help of an intact aortic valve, it will not go into the left ventricle, it will go into the coronary ostia and perfuse the myocardium. Once this occurs, the heart will go into hyperkalemia and heart arrests in asystole. There might be special situations, like you have an aortic regurgitation or you have to do an aortic root surgery. At the time, we open the aorta and directly give the cardioplegia into the coronary ostia. It is called ostial plegia. Sometimes the plegia might not go into the myocardium, as in case of a left main coronary artery occlusion. At that time, you will have to cannulate the coronary sinus and give retrograde cardioplegia so that it reaches the myocardium. If the purpose of CPB is complete immobility and opening of a chamber, the surgeon can only start from this point, and now the heart is ready for undergoing a surgery. So we'll see a video on how we deliver the cardioplegia. So that is the cardioplegia delivery line. It is de-aired and secured into the aorta. Next, what we'll do is we'll have to put a cross clamp. So to isolate the systemic circulation and the coronary circulation, the cross clamp is applied here to isolate the systemic circulation and the coronary circulation. So how to maintain the CPB? During the CPB, you can't relax. You have to maintain the anesthetic levels. More importantly, you have to do a proper monitoring during the bypass and maintain the anticoagulation status. The perfusionist will take care of the heart. He will give cardioplegia every 20 minutes. So what all should you monitor during the bypass period? See, the monitor is there. On the monitor, you have to always look for a flat ECG. Now, we have purposely arrested the heart. The heart should not have any electrical activity. Any electrical activity, the no perfusion period will give rise to ischemia. So you have to keep looking at the ECG so that there is a flat line. And the mean arterial pressure should be 67. I'll tell you in the next slides why this mean arterial pressure should be maintained. Though it is a non-pulsatile flat line, you have to maintain the mean arterial pressure. And you have to maintain the temperature. So you have to look at the temperature also. On the patient, you have to look at the pupils, conjunctiva, and the urine output. And you have to keep repeating the ABG so that you have the blood gas values. I'll tell you also about how to maintain the blood gas also. So this PO2, the importance is now you do, because it's a non-pulsatile flow, the pulse oximeter will not work. So you have to only rely on the PO2 values to see whether there is a systemic oxygenation. So pump perfusion and the perfusion pressures. So because the pump is rotating, it will deliver a cardiac output of 3 liters per minute. So that depends on the rotation, the roller head occlusion, the tubing size. It will give a line pressure of 80 to 120 millimeters of mercury. That will reflect in the patient as 50 to 90 millimeters of mercury, which is dependent on the peripheral vascular resistance, hemodulation, and the viscosity. So because the patient is fully heparinized, there is risk of bleeding, and there is a if you maintain low MAPs during the CPB, you have less risk of bleeding, but the risk of organ hypoxia is always there. If you maintain high MAP, there will be good organ protection, but bleeding and embolism risk is always there. So this is how they give a systemic pump. See, he is giving 3.3 liters at a pressure of 152, and the pressure on the patient is 58/39. So we'll briefly look at the acid-base changes in the patient. Now I have cooled the patient to 33 degrees and I draw a ABG sample and send it to the analyzer. What happens is this ABG machine will warm the blood to 37 degrees and then give a report. So the report will look very normal. The pH is 7.4, PCO is 40.2. But if I enter the actual temperature of the patient into the ABG machine, it will give another report that is called a temperature corrected report. Here you can see that the pH has become an alkalotic value, 7.55, and the PSC2 has gone down. All this value is the actual value which is in the patient. The patient is in a state of respiratory alkalosis. So what to do? If there is a respiratory alkalosis, there may be decrease in oxygen delivery, and because of the hypocarbia, there will be cerebral ischemia also. In the previous days, what they did was they always corrected this ABG after correcting the carbon dioxide. So they added carbon dioxide to the circuit and always maintained a pH of 7.4. This was called pH stat management. But once you give carbon dioxide into the circuit, what will happen is there will be cerebral vasodilation, there will be cerebral edema and embolization risk. So now what we have done is we are accepting this ABG value, which is uncorrected, and that is called an alpha stat management. So pre-weaning preparation, once the surgeon is about to finish surgery, the first thing he will do is he will tell the perfusionist to start rewarming. And in this phase, what you will have to do is you have to do an ABG, correct the ABG and electrolytes. Additional dose of, because the patient is in the rewarming phase, the hypothermia itself would have acted as an anesthetic. But now during rewarming, the patient will have light pain of anesthesia, and you will have to add opiates and hypnotics to the patient. And the inotropic agent is also stopped. So this is the Romanov-Roisky's famous CVP mnemonic during the pre-weaning phase. So we'll see an outline of how to wean the patient. So rewarming, next is de-airing. Then you will have to remove the cross clamp. Once you remove the cross clamp, ECG will resume first, and they will again have an empty beating heart. During this period, allow the heart to recover from the ischemic damages and accumulated metabolites. Start inotropes and vasopressors during this time. And once the heart resumes its full contraction, you reduce the venous return and allow the blood to fill the heart, and the heart ejects by it on its own. At this point of time, pulmonary circulation will start, and you have to start ventilation. And once the slowly you start weaning the patient, once the cardiac output, blood pressure, rhythm, or everything is normal, you can switch off the bypass and go in for an aortic venous decannulation. See, when you started the bypass, you always put the venous lines, aortic lines first. But when you remove it, you have to remove the venous lines first, restore the coagulation with help of protamine, and do the aortic decannulation. So why should you de-air the heart? Once you open the chambers of heart, all the air would have entered. And once you resume circulation, the air from the heart will go into the patient. So you have to de-air the left chambers completely. That is done by opening the, reversing the flow from the cardiopulmonary delivery line, or putting vents into left ventricle, the pulmonary artery, or the right superior pulmonary vein. So once the patient is completely de-aired, the cross clamp is removed. Once the cross clamp is removed, the blood from the systemic circulation will rush into the coronary artery and flush the cardiopulmonary solution out. The electrical activity of heart will start to resume. See, when you went into the pump, it followed the features of hyperkalemia and it went into an arrest. Now here, from an arrest, through features of hyperkalemia, the sinus rhythm will start coming. But even if it doesn't come, it's no problem. You can put on pacer and allow the heart to contract well. See, I'm ventilating the patient, and all the blood from the lungs is coming into the left atrium and de-airing the left atrium after the mitral valve replacement. After this, the surgeon de-airs the left ventricle by opening up the cardiopulmonary line and giving some blood into the heart. All the air from the left atrium and the left ventricle will come out. So the left atrium is completely de-aired. He has closed the chamber. He is de-airing the left ventricle also. Now the patient is ready to be cross clamp removed. After the cross clamp is removed, it will become an empty beating heart. Wait for some time, let it beat and regain its original contractility with the help of inotropes. Then you can start filling the blood. Before you do that, you have to see, before you fill the empty beating heart with blood, you have to make sure that there is a sinus rhythm, a narrow QRS complex, and the patient is stable with a good pH. There should be no hyperkalemia. Temperature should have reached 37 degrees, and the myocardium should be contracting well. So the venous drainage is slowly reduced, and you have to start ventilating at this time. The ETCO2 and the blood pressure will start to rise. You may have to increase the supports. If there is distension, you have to increase the supports. But if the heart is contracting well and the BP is not still picking up, you will have to add volume to the circuit. See here, the perfusionist clamps the venous line, and he slowly reduces the venous reservoir volume, and at the same time, he also reduces the forward flow from the pump. So to resume anticoagulation, after the surgeon decannulates the SVC, once the bypass is off, he'll remove the SVC cannula, and you have to slowly give protamine into the peripheral line. You have to give only through the peripheral line we will give, and it's only after a test dose. We will measure 3 pressures. One is the filling pressure, the systemic pressure, and the airway pressure. We have to monitor so that any heparin reaction you can identify. 1 milligram of protamine is given for 100 units of heparin given. Easy to identify, easy to remember is for each cc of heparin, that is 5,000 units, you will have to give 1 ampule of protamine. 1 ampule of protamine contains 50 milligram. And once you give full anticoagulation, the ACD should come back to 120 seconds. And once half dose of protamine is over, you should notify the surgeon and he will take the aortic cannula out. You can continue the remaining amount of protamine. So in the postoperative period, we'll correct the fluid blood deficits. Temperature should be normalized. Acid base should become normal. And recovery from anesthetic agents in the neuromuscular block, you can extubate the patient. For fast tracking, that is early extubation, you have to plan the anesthetic in a different way. So what is deep hypothermic cardiac arrest? Sometimes you will need procedures which are done on very small neonates for long periods, or an IVC or a AV malformation, where you will completely need bloodless field. And to have that complete bloodless field, what we do is we run the CPB, start cooling. By around 32 to 30 degrees, the heart stops by itself. Continue cooling up to 20 degrees. See, deep hypothermic level is 20 degrees. Continue cooling. By the time ECG flattens, it means that the brain is also completely protected. You stop the bypass and then you start the surgery. So there is no circulation in the body at all. This is called a deep hypothermic circulatory arrest. You would have seen all the organs will be preserved by the deep hypothermia. People falling into ice caves, they become preserved in a similar way for a short period of time, that is up to 60 minutes. In this very deep hypothermia, you can preserve all the organs. But the only organ which needs maintenance is the brain. So how to neuroprotect? That is done by head cooling, pharmacological agents like thiopentin and magnesium. You can also do a selective cerebral perfusion through either the innominate artery or retrogradely through the IJV. Give oxygen. You have to keep giving oxygenated blood into the brain. And the neuro monitoring is always a must when you go for a DHCA, especially the electrical monitors. And we have to follow a pH strategy here. That is adding carbon dioxide to the circuit and maintaining pH at 7.4 to ensure that there is maximum cerebral vascular dilatation. Coming to pediatric CPB, there are only 3 differences. See, when you add pump prime, the hemodilation is only 30%, but in a pediatric patient is 300%. So you always have to give blood into it. And the ABG strategies, most of the time it is pH stat. The PaCO2 will be very low here. So these are the main differences. CABG, there's a block in the coronary artery. You have to bypass that and give a distal perfusion. You can do it by 3 methods. Either you can go for a full CPB, the arrested heart, or a partial CPB and produce a fibrillatory arrest or a beating heart. The main advantage is you can always go, if the heart is good, you can go with the no CPB and a beating heart. So the anesthetic goals are give heparin at a lower dose and maintain ACT at 240 to 360. You have to give slow heart rates because the surgeon operates it on a stabilizer. And for the comfort, you have to give slower heart rates, maintain coronary artery perfusion pressure. I'll tell you the next slide how to do it. Prevent arrhythmias and prevent hypothermia. So coronary perfusion pressure perfusion always occurs during the diastole. So the formula is aortic diastolic pressure minus the opposing force is the left ventricular end diastolic pressure. So maintain good SVR so that the aortic diastolic pressure is high, and good inotropy so that the left ventricular end diastolic pressure is very low. This can be achieved with the help of a noradrenaline infusion. And unconventional types of bypass. The first is a left atrium femoral artery bypass. You can draw blood from the left atrium. Here, this is the left atrium. Draw blood from it after oxygenation from the lungs, and through a small circulation, you can give it into the femoral artery. So this type of surgeries can, this type of method can be used in thoracoabdominal aortic repair. Femoral bypass commonly used in ECMO. Blood is taken out of the femoral vein, oxygenated and pumped back from the CPB and returned to the femoral artery. It's called arteriovenous bypass, or the femoral vein is called venovenous bypass. It's commonly used in ECMO, anticipated airway loss, redo surgery at deep hypothermic cardiac arrest. Can also arrest the heart even without doing a thoracotomy. See, there's a cardioplegia line going in, and there's a balloon there. Instead of crossing, the balloon occludes the aorta and delivers the cardioplegia. To summarize, first is sternotomy, heparinization, aortic cannulation, venous cannulation, partial bypass, then he go on for a full bypass, cool the patient, give a root cannula and put the cross clamp, deliver the cardioplegia, that will arrest the heart. And once the surgery is over, you rewarm the patient, DR the patient, you remove the clamp and the ECG and the mechanical activity resumes, start the inotropic support, you reduce the venous return, start ventilation and do the weaning. And once the weaning is complete, you go off bypass, do a venous decannulation, give protamine, and after protamine, you half dose of protamine, do an aortic decannulation, check for hemostasis, and close the chest, shift the patient to CT-ICU and extubate later. So I thank for a patient listening. Thank you.
Thank you, Sivaprasath, sir.
Thank you, sir.
Wonderfully elaborate. Those who are not witnessed CABG, that is open heart surgery, it will be more useful. Gomani madam, there are some questions in the chat box. Unmute yourself, Gomani madam. Gomani madam, unmute.
Okay. Sir, shall I answer the questions like Kaushik start presenting, sir?
Okay, you answer
the chat box, sir.
Okay. Gomani madam, we can move on to the next topic.
All right. The next topic is basics of echo evaluation by Dr. Kaushik Jothinath. He is a consultant pediatric anesthesiologist at GKNM Coimbatore, and he's also the author of Anesthesia Review for Dependent Students. Dr. Kaushik, over to Dr. Kaushik.
Am I audible, everybody?
Yes, you are.
Yes, sir.
So thank you, Gomati ma'am, for a very nice introduction, and also Edward sir for having me on board. Very elaborate presentation by Vinothini ma'am and also Sivaprasath sir. So for a moment, I thought that I was working on a Sunday morning. So it felt very live, your presentation, sir. Just give me a minute. So are the slides with? Are the slides visible?
So your audio is breaking.
Yeah, audio is
Video
breaking.
is also hang up. Your video also hangs. You can stop your video and start. So. Now you can share your slides, sir.
Can you hear me, ma'am?
Yes, audio is clear.
Yeah, back on. Sorry, I'm having some bandwidth issues. Let's just get back to the presentation. So I'll be talking to you about the basics of echocardiography. I've been given 15 minutes. It's quite a short while. So a couple of disclaimers before we start. One is, if all of you find yourself in this state at the end of the lecture, I shall try and change the style of presentation for the next few sessions. The second one being that it's a very basic outline of ventricular function. It doesn't cover a lot of echocardiography. It basically focuses only on ventricular function and especially on systolic function. So we should be looking at the equipment which we need, some of the basic views that we use, and some of the indices of systolic ventricular function. So let's jump straight back into a clinical scenario. You have seen a patient who's 51 years old. He's a diabetic hypertensive with COPD. and you're on call, and in the night you suddenly receive a call saying that he's turned breathless and he's got sudden preoperative hypotension. So what do you do next? Well, echocardiography is something which is a very useful tool, and which I believe every anesthesiologist should be familiar with in the coming years. So this person had an echocardiography done. The anesthesiologist who was on call was able to get these windows. So on the left, you have a 4-chamber view, and on the right, you have a short axis view of the left ventricle. You can see that the ventricle is struggling to perform adequately. So how does this person get to this stage? So as we all know, we all need the right tool for the right job. So any ultrasound machine would do, provided that we have a phased array probe. You have to have a phased array probe so that it is low frequency and it allows enough of tissue penetration to be able to visualize the heart. And you would ideally prefer a frequency range of around 1 to 5 megahertz. The reason we prefer a phased array probe is that it has a very small footprint, so it allows for easy manipulation in between the intercostal space. So a few basic rules to remember. One is that the probe marker always is present on the probe of choice. So it can either be in the form of a light or a dot, or in this picture, your ridge. And the probe marker is always indicated on the screen by a dot or a letter. The V of the sector is always where the probe is at. So this is important to remember, because in transthoracic echo, this would the V of the probe, the V of the sector would represent anterior structures, whereas in a transesophageal echo, this would represent all the posterior structures. So likewise, the farthest structures are displayed at the bottom of the sector. So let's jump on to some basic TTE views. We should be familiar with 4 views. However, we're going to be running through 3 of these views, that is the parasternal windows, the apical windows, and the subcostal windows. So first being the parasternal long axis view. So for this,
sir, are you running your slides? Are you running your slides? It's not.
Sir, yes, sir. I am.
Your slides are not visible.
Slides are not visible?
Yes, sir. You are not shared on screen.
Where are we stuck, sir?
Yeah, you are running the slides by your lecture.
Okay.
Are you running your slides also, sir?
Yes, sir. Running the slides.
So it's
Your
not
slides
visible.
aren't visible.
Oh, I'm still at the first slide, is it?
Oh, okay. Now only it is visible, sir.
Okay, sure. Sorry for that.
It's okay. You can take your time. We are just seeing the video. We are just seeing your PowerPoint now.
We can extend time, no problem, sir. You can finish your topic.
Sure. So let's get back to this. Okay, so this is what I meant. The probe marker will usually be present on the probe, which can either be indicated by a light or a dot or a ridge. And this would be indicated by a letter on the screen. And the V of the sector is always where the probe is at. So this would represent anterior structures in transthoracic echo and posterior structures in transesophageal echo. And the farthest structures are displayed at the bottom of the sector. So the basic TTE views, we should be familiar with the parasternal windows, the apical windows, and the subcostal windows. We'll be running through those. The parasternal long axis view, basically you'll have to keep the probe at the left sternal border in the 4th intercostal space. And the marker is usually directed towards the patient's right shoulder. The optimum depth for obtaining these images would be around 12 to 16 centimeters. And like we can see in this video, it is used to evaluate the RV outflow tract device. So it is usually pointing towards the patient's left shoulder. Optimal depth for obtaining this window would be around 12 to 16 centimeters. And this, while we are or the mid-papillary level of the left ventricle. So like we can see, we can have a cross section of the left ventricular cavity, and this is useful to assess the left ventricle as well as the right ventricle. The mitral valve, if we to point the probe position when it comes to the parasternal long axis view when it's pointing towards the patient's right shoulder, and the parasternal short axis view where it's pointing towards the patient's left shoulder. So next we have the apical four-chamber view, wherein the probe marker is, the probe is first of all kept at the place of the apical impulse, and the indicator usually points at the 3 o'clock position, and the optimal depth for obtaining this view would be around 14 to 18 centimeters. And like we can see a nice four-chamber view wherein you're able to see the left atrium, left ventricle, right atrium, and right ventricle, and the tricuspid and the mitral valve in between. Next, we have the subcostal view, that is a four-chamber view. Again, the probe is placed below the xiphoid process, and the marker is kept towards the left shoulder. Ideally, it is usually at around 3 o'clock position. The optimal depth for obtaining this view would be around 16 to 24 centimeters, and we can see here that the four-chamber view again pops up. However, we have the liver shadow, which is seen on the left of the screen, useful in evaluating the left atrium, left ventricle, the right atrium, and the right ventricle, as well as the mitral and tricuspid valve in between. And we have the subcostal IVC view, wherein it is placed at the same position, that is in a sub-xiphoid level, and the probe marker is rotated 90 degrees so that it's pointing at around 12 o'clock position. And we can see that the IVC gradually enters into the right atrium. This is usually useful to assess the volume status. So for this patient, we shall be jumping on into evaluation of the ventricular function. So first would be qualitative function. And of course, it requires quite a bit of time for us, quite a bit of experience to calibrate the eyeball before we'd be able to call it as a good LV function, a mild LV dysfunction, or a severe LV dysfunction. So
Your audio is breaking, sir. You're not audible.
Here we have it easy because we have 3 slides for, three. Can I go on?
Yes, sir. It is audible, sir.
Okay, audible. Yeah. So qualitative assessment, usually the accuracy depends upon the quality of the image. So you need a good quality image with good endocardial windows, which is especially difficult when it comes to the lateral and the septal walls of the left ventricle. And like we discussed, you need to calibrate your eyeball over the years to be able to call the ventricular function right. So a lot of it depends upon the experience of the examiner. And lastly, your regional wall motion abnormalities may end up confusing you with what exactly would be the ventricular function. So another important step which we need to know, a very basic thing which we need to know before we proceed into the various indices, we need to be able to identify what time of the cardiac cycle we are at. So in this video, we're looking at how to identify the end diastolic frame. So let me just pause this video and loop it. So we can see that here the mitral valve is slowly opening up, and this is the LA, this is the LV. Mitral valve is slowly opening up and it's allowing the LV to fill with volume. You can see the LV distending, then the mitral valve comes to closure, slowly comes to closure. So so the window we need so as to call it as the end diastolic frame would be the frame just before the mitral valve closes. So again, I'm going back a few steps, a few frames. The mitral valve again remains open, and now it comes to a close. So this would be the frame that you would want to call it as the end diastolic frame. So the next would be your end systolic frame, that is playing on the right of your screen. Let's again toggle to the first half. So you have a full heart, the mitral valve is closed. Now I'm starting to run the loop, you can see that the heart is contracting, the volume reduces, the mitral valve is still closed, heart is contracting, and now the mitral valve opens. So you want the frame just before the mitral valve opens. So again, I'm going back a few steps to where the mitral valve just closes. This would be the end systolic frame. So now you've identified what is the end diastolic frame, what is the end systolic frame. So if you see here on the bottom right corner, you have an ECG reading along with the loop. So the ECG reading usually leads to the end of the T wave. That is where your end systolic frame is at. End diastolic frame usually lies within the QRS complex. This was a previous video. So another basic thing we need to understand would be the M mode echocardiography. What exactly is M mode echocardiography? M mode is basically to be understood. This mode basically defines with the motion of structures which is within your sector. So to understand this, you must understand that we talk about M mode. It is actually a point which is going somewhere. So that is how your structures become lines on the sector. So when we choose the M mode, you see that a white line crops up, like in the bottom of the screen, you see a white line crops up, and this white line divides the entire image into a series of dots. So each of these dots are traveling somewhere over a period of time. And that is how you get these lines at the bottom of that image. So this M mode is useful in identifying fractional shortening, which is an index of ventricular function, ventricular systolic function, and also the IVC diameter, which is useful in assessing the volume status. So three basic indices that we shall deal with in today's session. One is your fractional shortening, fractional area change, and ejection fraction. And all of these we should remember is nothing but full heart minus an empty heart divided by a full heart. So that is what you're dealing with when you're talking about all of these indices of ventricular function. That is the diastolic frame minus the systolic frame divided by the diastolic frame. And depending upon what you're talking about, either the left ventricular cavity diameter or the left ventricular area or the left ventricular volume, you would either call it a fractional shortening, fractional area change, or an ejection fraction. So actually you're talking about ejection fraction in one dimension when you're mentioning fractional shortening, two dimension when you're talking about fractional area change, and three dimension when you're talking about ejection fraction. So that should form the basic of the following few slides in the lecture. So that is nothing but ventricular function is measured by saying diastolic minus systolic divided by diastolic. So first we come to your one-dimensional estimate of ventricular function, that is the fractional shortening. So here, like we discussed earlier, we're talking about the change in the LV cavity diameter. So you're using the diameter to define your ejection fraction in one dimension. So the normal value would be, abnormal value would be when it is less than 27% in females and less than 25% in males. And like you see in this picture is just one dimension, that is a change in height. So similarly, it's just a change in the LV cavity diameter. So the fractional shortening, how do we optimize this image? First of all, it is taken using your M mode. And once you choose the M mode, the white line will be dropped. And this white line is ideally placed just below the mitral valve leaflets at the caudal level. And this is placed perpendicular to the long axis of the LV cavity and can be obtained usually with two views, that is the long axis view as well as a. So what are the advantages of this method? I think all of us should be familiar with this because it is, for one, it is very simple, very easy to perform, can be obtained very quickly, and even our sonocyte machine has this mode, so it can be a very quick estimate of ventricular function. So we shall go through the steps of how to get this fractional shortening. So first would be to acquire an image like this, that is using your parasternal short axis view. So we've got a nice cross section of the LV cavity. And then we drop the M mode line. So we have the M mode, which is cutting across the LV cavity. So the next step would be to choose your M mode on the on the keyboard of the machine. So you have the M mode button, you choose that, and this is what the monitor throws up. So you have the M mode line, which divides this image into a series of points, and this bottom image shows you the movement of those points across time. So out of this, you need to identify the LV cavity. So that would be the dark space in between. And you measure that LV cavity during diastole, and you measure it during systole. And once you do that, the machine software calculates your fractional shortening, and it displays the fractional shortening along with your one-dimensional ejection fraction and various other indices. So that would be how you measure the fractional shortening. Next, we come down to fractional area change. So like we discussed, fractional shortening is a change in diameter. Fractional area change is a change in your LV cavity area. So it is ejection fraction in 2 dimensions, and the normal value would be when it is more than 35%. So how do you optimize these images? We shall be going through the steps of obtaining this fractional area change over the next few slides. So the image acquired would usually be in your parasternal short axis view, like for the fractional shortening, or you can also use the apical 4-chamber view. And again, like before, we need to identify the end systolic and the end diastolic frames. Your endocardial border is traced in between the mitral valve annuli, and the fractional area change is automatically calculated by the machine. So here we have again acquired a parasternal short axis view of the LV cavity. And now we have identified, like before, the end systolic frame and the end diastolic frame. Should pardon me for the quality of the videos. I've had a merciless couple of weeks at work. So this was just recorded yesterday in theater. So you can see, let me just run this slowly. So you can see that at the bottom right, you have the end systolic frame. That is basically the red dot, which is sitting at the end of the T wave. And on the left, you have the end diastolic frame. The red dot is buried in the QRS complex. So this way of tracing the endocardial borders is wrong. We should be looking at it at the next couple of slides. So now we have identified the 2 frames. We have traced the endocardial borders. So the end diastolic border and the end systolic border. The trick is to include the papillary muscles when you're tracing the border, and that is why the previous slide was wrong, wherein we have excluded this papillary muscles while tracing it. And once we do that, the area is displayed on the left corner of the screen, and you can calculate the fractional area change. So this would be the wrong way of doing a fractional area change calculation. That is the tracing the endocardial border, wherein we have not included the papillary muscle. The blue line excludes the papillary muscle. This would be the right way, wherein you have included the papillary muscle and the blue line includes the papillary muscle. So our machine is calibrated to display the fractional area change automatically for the 4-chamber view. So this was done during the case with the transesophageal probe. You can see that the LV fractional area change is close to normal. It's around 30%. So if you're still awake, I hope you are, because the next few slides are what everyone is interested in. That is the ejection fraction. So the ejection fraction basically measures the systolic change in the LV cavity volume. So it is nothing but all of these put together in 3 dimensions. And the method which is preferred, which is recommended by your ASC and all other academic forums, is the Simpson's method of discs. So normally it should be more than 55%. And what is the Simpson's method? It is nothing but a summation of series of discs. So like you have the fractional area change, you have to trace out the endocardial borders. And once you trace out the endocardial borders, the machine drops a series of discs from the mitral valve annulus right up to the apex. So again, while doing this, you'll have to choose your end diastolic and the end systolic frame. The end diastolic and end systolic endocardial borders are traced out, and then the machine sums up the discs between these borders and creates a volume. So what are the advantages? It is one of the most widely regarded indices of cardiac function. Almost all of us, the first thing that we look at before we look into an echo report is the ejection fraction. So the disadvantages are that it is time consuming, and because we are cubing everything, we are looking at a three-dimensional aspect of a single measurement, all the errors are magnified. So that is one of the major disadvantages. And another thing is that it is load dependent. So it is a load dependent measure of contractility. All of these indices that we have discussed in the previous few slides are all dependent on both the afterload as well as the preload. So if you have a full patient, your heart is going to look like it's not contracting well. And if you have an empty heart, it looks like it's going to be contracting much better. So that is what it means by load dependent. So it is preload dependent as well as afterload dependent. So how do you go about obtaining this ejection fraction? So first thing you need to do is to acquire an image. We have here acquired a mediastinophageal 4-chamber view of the heart, and we have the LA and the LV. And again, we need to choose the frame. So we look at the end systolic frame. That is, the red mark is at the end of the T wave, and end diastolic frame, wherein the red mark is buried within your QRS complex. So once you have done that, once you've chosen the frame, we go on to tracing the endocardial borders. But before that, we need to be able to identify where exactly the measurement should be taken. So we press the measure button. Yeah, so we press the measure button, and this is what comes up. Now you need to scroll down. You need to scroll down to where the volume is at. So you click on that, and then you have your ways of measuring the ejection fraction. Now you're going to choose a single plane way of measuring the ejection fraction. And this is basically the left ventricular end diastolic volume on the left and the end systolic volume on the right. So once you've chosen the end, once you've traced the endocardial borders, the machine is going to throw up your ejection fraction automatically. So this is what we're going to be doing next. So we are tracing out the endocardial borders. We are careful enough to include the papillary muscles. And on the left, we are doing it for the end diastolic frame. So you have dropped it, you've dropped the line, and the machine throws up a series of values on the left corner of the screen. You have the end diastolic volume, end diastolic area, etc. Now you've gone on to the right. So you're going to be tracing the end systolic frame, the endocardial borders. So we've started from the mitral valve annulus, going through tracing all the endocardial borders. Be careful enough to include the papillary muscle, and you go up right up to the opposite side. So once you've done that, you drop a line, and the machine displays the ejection fraction. It displays the stroke volume, your cardiac output, and your end systolic dimensions. Again, I'd like to apologize for the quality of the slides. So with that, we come to the end of this talk. It's a very brief talk, firstly because of the short duration. I thought I'll just give you what most of you would be interested in learning. So you are your own limit and rise above it. So I think going ahead, all of us will need to know how to do all of these. And if you're somehow able to find yourself with a machine somewhere, I think each one of you should familiarize yourself with this. Thank you.
Thank you, Kaushik sir. I know there is a time limit. We can have a part 2 also, sir, with elaborate time. Sorry for the time limit today. We can go for a part 2 also, sir, in the future, the next month. Thank you so much for your wonderful presentation. Gomadi madam, you can conclude.
Thank you so much, Kaushik sir. And as Edward sir said, we would also like another session where we can have a more comprehensive outlook with more time. So I think everybody will want that. Thank you so much. So can we wind up? There are no questions in the chat box. If there are, it can be answered. So we can wind up.
Thank you, Gomadi madam,
Thank you.
for heading this session. Thank you for the today's speakers, Sivaprasath sir, Sarva Vinothini madam, and Kaushik sir. Thank you, one and all. We can meet the next week. Next week is going to be a case discussion involving a valvular heart disease. So it is going to be an interesting one. Thank you, one and all. Thank you, AM Logics. Thank you, Akrula. Thank you. So we can wind up sessions.
Thank